So tonight we have a wonderful panel assembled with Dr. Charles Begley leading as he did last year, and I'll leave further introductions to him. Dr. Begley, thank you.
Okay, I'm going to be on wire. Yeah, cool. All right, good evening, everyone. My name is Chuck Begley, as Steve said, and I'm on the faculty of the UT School of Public Health. And we have with us, I'm delighted to say, on my right, your left, Annalee Gulley, who is Director of Public Policy and Government Affairs at Mental Health America of Greater Houston. And she is going to be our expert tonight on state health policy process related to the legislature, the legislative process, how it gets done, and the responsibilities that the state takes on with mental health policy. We have Tim Schauer on the other end over here. Tim is Senior VP of Cornerstone Government Affairs, and he is our expert tonight on Medicaid CHIP policy and the state budget. And finally, Freddy Warner. Freddie is Chief Government Relations Officer for the Memorial Hermann Health System, and tonight he's going to be our expert on local health institutions and policy. So as this lineup suggests, well, first of all, I would just like to thank all three of these people for being here tonight. It's an extremely rare accomplishment to have these three in the same room talking about state and local health policy. And in particular, to have it during a legislative session is just a super accomplishment, and I think really reflects their dedication to helping us all improve health policy for Texans. So I really appreciate you guys coming over. All right, so the way we're going to do this is we're going to try and make some presentations and lead a discussion with you to all get a bit deeper understanding of how state and local policy gets made. Okay, and we're not going to be able to cover the whole waterfront. We are going to cover legislative process. We're going to cover the state budget a little bit, and this is going to be at a high level because we have later topics in this class where you will get into some later sessions where you'll get into some of these topics in more depth. So this is going to be mostly overview stuff that we're doing, and then Freddie on local health policy institutions. So we're not touching the policy that comes out of our state agencies in terms of rules and regulations and program management. And there are a variety of other places where we get very important state and local health policy. But we are going to cover these big three processes to some extent. We're also going to cover the state policy role with respect to, as I indicated by the speaker's topic, Medicaid CHIP, mental health, long-term care, and health workforce from Freddie, okay? Again, in trying to cover, state and local health policy in an hour and a half, you cannot cover everything. So we are not touching on public health for the most part, natural disasters, emergencies, quarantines, food, air, water, none of that tonight. We're not covering anything having to do with regulating health insurance that the Texas Department of Insurance does. We're not having anything to do with school health, prison and jail health, traffic safety. So there's a lot of the waterfront that we're not covering in state and local policy, but by focusing on these, Medicaid CHIP, mental health, health workforce, and long-term care, we are picking up four of the biggest dollar items that we have. And then finally, although I've told the panelists not to go too far in the direction of discussing current issues in these these areas, in these programs, in these policy areas, because we have whole sessions scheduled later in the semester on these very topics. But we'll just introduce some of them and give you some flavor for what's going on currently. So without further ado, I'll turn it over to Annalee to give us her presentation on the legislative process and mental health. Oh, I just wanted to say, we're going to do this in 10 or 15 minutes each. Sorry, Annalee.
Okay.
I'm just being rude. Unorganized. 10 or 15 minutes each with maybe a burning question at the end of each presentation. And then we should have 30 minutes or so at the end for a general discussion.
Thank you, Dr. Begley.
Yeah.
Hi, my name is Annalee Gulley, and I am the Director of Public Policy and Government Affairs for Mental Health America. Full disclosure here, I thought we could have slides and found out we could not. So I'm still going to use mine, so bear with me. But what I wanted to talk to you a little bit about this evening is just kind of the makeup of the legislature itself, how often it meets, just kind of the advocacy 101 of the legislature, and then go through a little bit about what it takes to get a bill through the legislative process. And then at the end, we'll try to touch upon mental health if Dr. Begley doesn't stop me. So the legislature is a bicameral body, so there's a Senate and a House. The Senate has 31 members, the House has 150. The way that that's broken down after the most recent election in November, we've seen the margins of Republicans to Democrats really narrow. I think you'll see that more in the House than you would the Senate, but it's definitely been a fairly significant change, and we've already seen the effects of that change when we got into the speaker's race, which I will get to in 1 second. But the session meets every other year. It starts on the first Tuesday of January in the off years, and the legislative session runs for 140 days. So every other year for 140 days. And my favorite part about it is that the Texas legislature has one job in that 140-day period. All they have to do is pass a budget. So if they pass a budget, they can go home and be considered successful. So there's that. Might explain some of the things that we see. So the Senate is presided over by the Lieutenant Governor, which is currently Dan Patrick. That means whoever presides over the body gets to determine the committees. So which senators, which representatives are going to be on the committees. And that really affects what happens to your bill, depending on which committee your bill gets sent to. You can have widely varying results depending on committee makeup. An interesting thing to note this session is that in the House, for the first time since 2009, we have a new Speaker of the House. Joe Strauss has been a very moderate Republican leading the House since 2009, and this year the House of Representatives elected Representative Dennis Bonnen from Angleton, which is a little bit outside of Houston. And we don't know a lot about Dennis Bonnen. He was very much like an ally of Speaker Strauss, so he's sort of viewed to be in that vein, but we also know that he is one to kind of buck the tide in terms of how he feels. He's not afraid to go against his party's positions, and he can get a little rowdy on that floor, so it'll be fun to watch. The interesting part about all of this is I think the Speaker really determines the tenure of the body for the House, and so we're all going to be kind of feeling around in the dark for a little bit to see how Representative Bonnen, Speaker Bonnen, wants this all to play out. He has mentioned that one of his top priorities will be school finance, and we know that that'll be addressed early on in the session. So those are the basics of the legislature. Let's talk a little bit about how to pass a law. I can write a law. Anyone in this classroom can write a law. It will be meaningless until you find a representative or a state senator who's willing to file that law for you. So if there is something that you care about, you're passionate about, as a private citizen, you can go to the legislature and find a representative to talk to about potentially filing your bill. If you get that representative will send your bill to Legislative Council, which is helpful because they know if things are actually legal or, fit with existing code, not just the things that like we make up on the fly. And so they'll send it back to the offices, and then at that point, the offices can file your bill. So a lot of what's happening in the session right now, which started on January 8th, people are waiting for their bills to come out of legislative session. Because it's all sort of fun and games. You're talking about strategy and what's going to happen, but until you have a bill number, you're going nowhere. So I got my first one last week, and I'm pretty excited. So once you get that bill number, the other thing we're waiting on is committee assignments. So the Senate announced their committee assignments last week. Again, that was under the direction of Lieutenant Governor Dan Patrick. We think there's a rumor that it'll be determined. Senate committees might come out tomorrow. House committees might come out tomorrow. Basically, your bill will be referred to a committee that's most appropriate for its subject area. Most of mine have to do with school-based mental health, so usually I'm in front of education. But if you have a really big champion for your bill, there's a chance that you might get your bill thrown out to that committee. Basically, what happens at that point is you need to make sure, like every bill will get referred to a committee. A lot of bills will die at that point. Not every bill is guaranteed a hearing. So you have to start fighting for your bill to get a hearing. Once you get a hearing, you have to start lobbying that committee to try to vote your bill out of committee favorably. Once that happens, you can do, if you're in the House, you'll either be sent to the local and consent calendar, which is awesome, or just go straight to the House floor. The benefit of going to the local and consent calendar is, for the most part, it's bills that are deemed non-controversial. They have kind of been stamped by the committee as bills that should be able to pass. You don't need to worry about them. You can just kind of rubber stamp them and move them on to the Senate. Bad thing about the local and consent calendar is that you can kill a bill on the local and consent calendar with 5 signatures from an opponent, from 5 opponents, or one representative can talk on that bill for 10 minutes. So while it's probably like 80% a great thing, there's just this like 20% danger zone that you have to watch out for. But either way, so if you pass your bill out of local, if you pass your bill through a full floor vote, the kind of exhausting and terrifying thing is then you have to start all over and do it again from the Senate. And so everything you just did starts over. And the exception to that rule is if you have a companion bill. So if you get a House representative and a senator who agree to file language that's word for word identically the same, then you speed that process up. It goes through each chamber at the same time, and ideally you have something that gets through quicker and is more easily passed. Other tips that I think are important. So there's some dates that are very critical during the legislative session. The first one is pre-filing. So pre-filing for the 86th legislative session occurred on November 12th. If you want to pre-file a bill, it's best if it's non-controversial. Because what you do when you pre-file, you get it in the queue first, it's great. You're really trying to get ahead of the game, but people have a chance to read through every single one of these bills and they can find problems with your bill. And that gives them more time to mount opposition to your bill. So if you have anything you think anyone might be a little bit opposed to, probably best to hold off. The first day of session was January 8th, and then you have a 60-day filing period. So you have time until March 8th in the session to get your bill filed. The sooner you get your bill filed, though, the earlier you get to start the game of getting it referred to committee, getting it heard before committee, and getting it voted out of committee. So you want as long of a runway as possible to make sure that you get through all of those steps in that 140-day period, because it goes very quickly. Even if you do everything kind of perfectly, you get it filed on time, you get through all your committee hearings, you go to the House, you're about to flip over to the Senate, there are still ways to kill a bill that you will have no control over whatsoever. And I have a list of them. One is to run out the clock. So if we're talking about you need this runway, basically the idea is you'll probably get your bill filed somewhere at the middle to end of February, worst case scenario, last week of March. So you need to get, whether you're on the Senate or House side, you need to get that through committee by April, at the end of April, early May. So if I am a legislator that is opposed to this bill, but I don't want to come out as opposed to it, what I can do is work with a committee chairman, work with an office to make sure we slow down the process so that it takes about 3 or 4 weeks to get you a hearing. And then after that, it takes 3 more weeks to get you a vote. And then after that, we don't know what happened. We're not sure why it didn't get referred out of committee. And so they can just kill your bill by slow walking the bill. Another option is to make a powerful friend. Same legislator goes to the governor, said this bill passed, but here's why you shouldn't like it. The governor still has the opportunity to veto that bill. Even if you get it through both sides of the chamber and feel awesome about yourself, you are not done yet. Just persuasion, again, if you start filing your bill early and you have someone who's opposed to it, they can mount a campaign against you. And that can kill your bill, despite how good your advocacy efforts are on that bill itself. Weaponizing parliamentary procedure. So that is kind of understanding how to use the clock, understanding when bills need to be filed, when they need to be heard, what dates they have to get through the House, what dates they have to get through the Senate, and using that against you. So just using every trick in the book to make sure you don't meet your deadlines. And then the final way, I mean, I'm sure there are more ways, but you know, I'm not that creative. So the final way that I know of is to inject a poison pill. So if the bill gets further than perhaps someone might like, and it's about to get a vote in committee or on the House or Senate floor, you can throw a really, really controversial amendment on that bill that you know is just a deal breaker. There's no way that bill is going to get passed with this, you know, $4 billion funding for SeaWorld or something. Like, you know, it's just not going to happen. So you can interject that, and most often it will get the bill done. Important dates, just so you know, November 12th, the session pre-filing began. First day of session, January 8th. Bill filing, March 8th. Sine die, which is the last day of session, will be on May 27th this year. And the final thing I really wanted to touch on was the biennial revenue estimate. So before every session, the comptroller will release an estimate of how much the budget can accommodate for the next 2 years. So you budget 2 years ahead. So right now, when we go into session, we are going to be creating a budget for 2020-21. And the comptroller releases an amount of money that is an estimate about how much we have to spend. So this year, he estimated that the General Revenue Fund, which is where most of our services are funded, had about $119 billion to be spent. That is an 8% increase from the last biennium. He also predicted that our Economic Stabilization Fund, which is more commonly known as the Rainy Day Fund, would be at about $15 billion. Don't get too excited about this, though, because these estimates were made throughout the entirety of last year, and in October, oil prices started to tank. So this is an estimate. We don't know that all of the factors that went into creating this estimate are going to stay consistent through the biennium. Also, we know that there will be a lot of Harvey infrastructure improvements that are going to have to be funded through this budget. Additionally, a big priority, or I guess two competing priorities of this session, is to make sure that we work on school finance and making sure that our schools have enough money. We also want to work on lowering property taxes. So those are just kind of inherently crossed purposes, and they ultimately mean that if we pay fewer property taxes, then we're going to have to invest more of that budget in education funding. Finally, when we talk about mental health, I think...
Annalee, could I forgive me?
Oh, you can do whatever you want. Yes.
Okay, thank you. You're being so kind. Could we ask for a couple of questions on the legislative process?
Sure, absolutely.
And then I want Tim to follow on the budget and come back to mental health.
Okay.
The nature of mental health policy. Let's get the process going first.
Perfect.
Done. Okay. Are there a couple of questions about the legislative process before we move to Tim's presentation of how this one bill gets through Congress, through the legislature? Yes.
What happens if the bill goes through the House and Representatives, but it doesn't but the president rejects it?
So I think ultimately, if it passes are you saying if it passes the House, but you can't get it through the Senate?
Yeah.
If ultimately you can't get a full majority vote in the Senate on your bill, then your bill dies. I mean, the other process is the veto. So if it passes both chambers, it then goes before the governor, who has to sign every bill to put it into effect. And that's when the governor, despite the votes of both chambers supporting the bill, has the opportunity to say, no, I think this is not in the best interest of the state, and veto the bill.
Okay, is this on? Okay. If we are interested in a certain type of bill and trying to get our state rep to file it or support it or whatever, how would we find out similar type people and like partner with them because, strength in numbers, it sounds like.
One of the things I would do, I mean, it's great that you're here. I'm not sure what brought you here tonight, but if you can continue to participate in group meetings with similar affinity groups, you'll be able to plug in with individuals who are interested in the same legislative issues that you might be. If you want to get my card, we do a lot of mental health work. If that's one of your areas of interest, we'd be happy to plug you into our efforts. But right now, we have Lindsay Lanigan from Legacy Community Health. They're the largest FQHC in Texas. We have a lot of representatives in the room who are mounting large advocacy campaigns, and we want to do everything possible to get constituents into that process. And then once you kind of become involved in that process, there are varying ways which you can be effective, but I always think that in-person meetings and phone calls mean the most.
An observation and a question. We're talking about the legislative process that's ongoing now. Everything that's been will largely be discussed and put forward on the agenda has already been decided. All right?
It's too late.
No. But I just wanted Annalee to try to characterize for the prior year and a half, certainly the last 6 months, there's been a whole process, much more informal than the legislative in-session process, of people, advocates, providers, legislators, working on deciding what bills they want to put forward in this session. We're not deciding on those things now. Those have been decided, and now the process is an argument about pros and cons and tweaks and modifications. Could you say anything to characterize the pre-session agenda setting?
I get asked frequently what I do when we're not in session, as if I work 5 months a year and then go to the beach the rest of the time. And I know nothing about baseball, but I compare it to baseball anyway. And during the off season, you are still training to play baseball. And so when the session is in, this is game time, and this is when it counts and when it matters. But the rest of time during the interim, you are building your case, you're building your coalition groups, you're writing your bills, you're finding your affinity networks, you're getting your authors and your sponsors so that you are in the best shape possible to perform well during that legislative session.
All right.
About regs, because implementation of the bill.
Oh, so that's thank you, Peg. So the other piece of this is implementation. So as soon as your bill gets signed by the governor, it will come into effect usually the 1st of September, and so you have to, if you work on a bill and you care about the issue and you want to see how that bill is implemented, it's really important to follow the interim hearings by the committee that passed your bill. So they keep on evaluating the efficacy and the success of a certain bill that they passed. But it's also great to go to state agencies who are tasked with implementing those bills. So last session, we worked on Sarah Davis's postpartum depression bill, and it's getting implemented through HHSC. So we've met routinely with HHSC because they have questions. When they're implementing the bill, they want comments, and they want from the community about what's the best way to do this. Because basically they get a directive from the legislature that you have to do X, Y, Z, but they're not given a plan. They don't exactly know how to put this in place. So they want community advocates and those who worked on the bill during session to be as available as possible to continue that conversation and help them determine the best way to implement the bill.
But we've got to stop the questions and go on. But Peggy, we said we're not covering the implementation process. We just don't have time. It's mostly done in the executive branch of government, and it's learning how the state agencies operate and how you can influence their operations and rules and regs. But we're not going to get into that in detail tonight. We're going to stay at the legislative process. And Annalee, if you would mind, let's turn it over to Tim to talk about the only bill that has to get passed during the legislative session, and then we'll get into our topical areas.
Thank you, Dr. Begley.
You bet.
And thank you to Annalee. I think she did a great job of kind of explaining the cycle. And one of the things that I like to talk about with this is that if you're a happily ever after person, don't get involved in policy. Because if you want to get to the end of the book and say, and they rode off into the sunset and lived happily ever after, forget it. Because that never happens. Even when you do win, if you ride off into the sunset, 2 years later, the people who fought you this time may come back and say, well, we don't like that bill, and they repeal the thing and it's gone. I'll use a great example. In the early 90s, Ann Richards, raise your hand, by the way, if you're from Texas, and if I reference things from 20 years ago, you'll know what I'm talking about. So about half of the room here will get a little bit of it. Is my microphone making a weird noise here? Can I just grab the hand mic real quick?
I think
Sorry, guys. Can we hear me now? Okay, there we go. That's clear. It was even noisy for me up here. So anyway, so if you're from Texas, there's been times where a governor or a group of people have really fought hard. And back in the early 90s, there was a really big push on adolescent pregnancies. And there was a big advisory committee that was formed, and a lot of people were really excited about it, and they made a bunch of progress. And unfortunately, when they came out with their recommendations and they said we need to improve our sex education of children, the state of Texas literally collectively lost their minds. And they said, oh my God, we've got to disband the whole thing. And they got rid of it, and they made sure legislation was passed that it never talked about sex education again. How dare you, right? And here we are 30 years later, and I'm pretty sure that we still don't talk about sex education in our schools, which you would think in Texas at this time you would be able to do that, but you'd be wrong. So let me talk real quick about one bill. And for those of you that don't know, former Lieutenant Governor Bill Hobby used to use this kind of introduction, so let me just quote him on this. The Texas legislature is about three things, and if you remember, Governor Hobby used to clear his throat a lot. It's about it's about money. It's about money, and everything else is just poetry. And to some extent, if you want to get involved in policy and you say, ooh, I don't want to dirty myself with dealing with money or finances, then you've missed 90% of the opportunities. Regardless of how brilliant a policy is, if there's no money behind it, if there's no programming behind it, if there's no agency to implement it or nobody to oversee it, forget it, it didn't happen. You got to follow the money. So let's talk a little bit about kind of principles of a Texas budget. What is a budget? Right? What is a budget? Well, first of all, it's in essence a reflection of your value. Whether you do a family budget or you do your community budget or whatever level your business, what are your values? Where are you going to spend your money? Every time you organize your personal budget, you are making value decisions, right? For those of you who haven't heard this before, this is a big, really big budget that reflects, whether you like it or not, the Texas values. Now, how do the elected officials know what those values are? Hint, it happened in November. It's an election, right? And this is where by, for, and of the people, I absolutely believe in by, for, and of the people. And if we don't vote and people get elected who don't think the way we do, shame on us. okay? That budget is going to reflect people who don't agree that healthcare is important, that health and human services are important, that the social determinants of health influence healthcare. Those things that I think most of us in this room would probably find some pretty close agreement with. If we're not out there being involved, and a lot of people go, ooh, I don't like elections either. Ooh, I don't want to, campaign, knock door to door? No way. Well, guess what? A lot of healthcare people have not done that for 30 years, and that's why in Texas, we have one of the worst Medicaid programs in the country. Lowest funded, by the way. It's actually a fairly well-run program with what we have. Poorly funded. We have the highest number of uninsured. We continue to fight the federal government, well, at least under the formerly Affordable Care Act, and now whatever's happening, it's kind of hard to tell whether we're fighting or not fighting, but we still need the money, right, to run programs. So the election is where the people of Texas tell the legislators, this is what we want. The other thing a budget is, particularly the state budget, is it's a planning document. It's not a lock-in thing that once you do it, it's a planning document that you look forward. And Annalee did a nice job of kind of introducing it. Why is it so hard to do? Well, how many of you know exactly what your family is going to spend 2.5 years from now? I don't. I mean, I have a ballpark. I know what my expenses are probably going to be, but I have no idea whether we want to go on a vacation that year or whether whether the job market is going to be the same. What's going to be happening with the economy? Is gas going to be $4 a gallon, or is it going to be $1.70 or whatever it is right now? Right? All these things happen, and the legislature right now is trying to project with this planning document not just what happens in a couple of months, but what happens starting in September of 2019 and running through August of 2021. So it's a planning document. Can they hit the nail on the head of exactly how many people are going to be here in the state of Texas? What's the level of poverty going to be like in the state of Texas? Will we have a bad flu season? Will we have, all these variables that influence the spending? And for everybody in the room, I can talk about the cone of uncertainty. We all know about when hurricanes are rolling in, right? And when it's like 2 weeks out, do we know whether that hurricane's going to hit us? Of course not. The cone of uncertainty is like from Brownsville to Florida. And you're like, well, that's not really helpful, right? That's 2 weeks out. But 3 days out, you're like, uh-oh, it's going to hit between Corpus and Houston. Now we're in trouble. Now we got to really pay attention. And 1 day out, or as it turns out, when Harvey's rolling over you, when it's happening, they're telling you, oops, we should have told you a couple of days ago, this is going to be bad, and sure enough it is, right? But when you're doing a budget, it's kind of the same thing. You've got to really look out into the future, and you've got to decide, A, how much tax revenue are we going to have? And B, how much demand for services are we going to have? Where do we spend our money? And almost every session since I've been involved in the Texas legislature, and I've been involved since '93, they usually come in and they say, here's what we expect we're going to have to pay, and oh, by the way, here's the amount of revenue we have. I think in my experience, this session is only the second or third time where we're actually starting at somewhat of a level line. As Freddie and I were joking, usually we start in a hole, and the question is how deep of a hole are we standing in? And we're really uncomfortable right now because we're standing on flat ground. I don't know what to do. I'm very uncomfortable not being in a hole. And so it's going to be kind of interesting that goes on. By the way, as was mentioned, the budget is actually the only job the Texas legislature has constitutionally. They could go to Austin, pass one bill, and go home, and they could say, check, we did our constitutional responsibility. That's it. Now, if they don't, they get to stay in Austin until they do. Fortunately, in the last 27 years, they've managed to pass a budget without having a big drama. But back in the late 80s, they were in until the final hours, and there was even some threats of shutdowns and all sorts of crazy things that happened in special sessions. But knock on wood, we haven't had one of those in over 30 years. So let's hope we can keep that streak going this year. So it's really key. But let me talk a little bit about the cycle, because to me, again, it's a 2-year cycle. And right now, some people think we're in the beginning of it. But I think as you heard from a few of the people, the beginning of it actually started, in my opinion, in September. And people who know the budget, they're like, what do you mean in September? No way, the fiscal year doesn't start. Well, why? Because the 10 weeks before the election, in my opinion, are the most key 10 weeks of setting a budget. Because that's when people are talking about the issues. Why do you think we're talking about property tax reform and school reform right now? Because during the 10 weeks of September, October, and the first week of November when the election happens, during those 10 weeks, that's what they talked about. So phase one of any budget is the 10 weeks before the election season, okay? Phase two of the election season of the budget cycle is the minute the election is over and you know who won, who's going to be the lieutenant governor, who's going to be the governor, who has the majority in the House, who has the majority in the Senate. All of a sudden, you're now into the, we better prepare our budget, right? And this is when they start putting pencil to paper. One of the steps that I've kind of left out because you could argue how important it is in the summer, in that 10 weeks when I'm talking about the election cycle, when most people are paying attention to the news, state agencies are filling out a series of questions that's called the LAR, the Legislative Appropriation Request. And they're directed by the governor and the lieutenant and the Legislative Budget Board on how to come up with their LAR. And for example, for as long as I can remember, every governor has said, give us a legislative appropriation request with at least 4% cuts in your agency, or at least 15%. They always ask for cuts. Squeeze your agency, squeeze your agency. And people wonder why our roads are falling apart and we have all sorts of issues in Texas, right? It's because for almost 30 years we've been squeezing the same amount of money, right? So that process is going along the way, but quite frankly, it's not very public. Not many people pay close attention to it. There's a few lobbyists that kind of sneak in and try to say, hey, we need this and this legislative appropriation request or that. I can tell you from my experience, and I've tried it both ways, the influence of that process is pretty much worthless. If you get the influence in the election, you're going to win. If you don't get the influence in the election, the LAR is nothing more than a bureaucratic process. Don't worry too much about it. But you have to have that in order to populate the budget, okay? Somebody's actually got to count the beans, right? How many people were on Medicaid last year? How many people were on CHIP? What was the average expense of every single one of those 0 to 5-year-olds, 6 to 18-year-olds? Disabled populations, the special populations, every single population group, they try to cut up and decide exactly how much are there. Because depending on how much you figure out, if that group grows 10%, can you calculate how much that's going to cost? So during the 10 weeks between the election cycle and the beginning of session, I call it the 10 quiet weeks because nobody's actually officially talking about the budget, but there's a lot of stuff going on behind the scenes. The numbers are being crunched, the documents are being worked, the initial drafts are going, and people are really preparing for that session. And I would also say, occasionally there's what I call posturing and pondering. And that's when you'll hear a few trial balloons come out, right? And the governor famously did it last session. He goes, you know what? We ought to fully fund pre-K. He really wasn't that committed to it. It was more of a trial balloon. Like, what do you think about that idea? I didn't run on it, really. I didn't tell you I was going to do it during the election cycle, but it sounds kind of cool. Doesn't that sound great? Let's cover all of our children with pre-K, full-day pre-K. And then they kind of did the math and went, oh, that's pretty expensive. I don't think we can do that. But it's a good time to kind of posture and put yourself in position to do that. Then, so we've gone through 20 weeks, right? The 10 weeks before, the 10 weeks of building. Now we're in the midst of the next 20 weeks, and we are in week 3. We're in week 3 of a 20-week legislative session. And this is when the big decisions are made. And the questions really come down to how much are you going to spend? How much are you going to tax? And where are things going to be moved around? Where do we stand? And following the budget process can be really tough. I got to tell you, just in the last 2 weeks, the House released a draft budget. The Senate released a draft budget, both of which are like 800 pages long. I might be exaggerating by a few, but not many. It's a big, big document. Don't print, by God. If you look at it online, do not accidentally click print. You will blow through an entire ream and a half of paper. Don't do it, okay? Just read it online or kind of skim through it online. But you'll notice that the House and the Senate versions are not the same. And then to make things even worse, next week we expect the governor to drop a draft budget. Now, in reality, There's not a whole lot of difference between the three. Usually they've got a little priority over here. The governor wants his pet projects. The House has their pet projects. The Senate have their pet projects. But in these next 140 days is you have these three budgets. And by the way, the legislators, for the most part, throw the governor's budget out immediately. It becomes a doorstop. The House only focuses on the House version. The Senate only focuses on the Senate version. And so then they start having hearings. And all of you in the room, if you're interested and you want to testify on your pet project, on the project that you think is important, for example, I'm working on vaccinations. I think vaccines are kind of important. I never used to have anybody on the other side until the last couple of sessions, and now we've got anti-vaxxers, and God bless them if they're watching on TV. They're crazy and they're wrong, okay? Dead wrong. There's no science behind it. If you believe in science and you believe in medicine, vaccines work. They're highly tested, peer-reviewed. They're right. We're right. They're wrong, period. Not many people will tell you that aggressively, but I'll tell you, after reviewing everything that I've been involved with, come on, people. And I've been working on improving vaccine rates, particularly for our children, since 1993. And we've been making tremendous progress. Texas should be proud of all the progress we've made until the last several years. And now we're going in reverse because of this kind of anti-science nutbag thing that's been going on. Sorry, I digress. Back to the budget. So that's an important thing to me. So I'll go and fight for that issue. We work with the Baker Institute and various other groups that fight hard to improve the vaccine rates. Most of the medical community is with us on this, and it's really important that they stick together. But they fight hard on that. But we will have to go and testify during the different sections of the bill. And for those of you in Health and Human Services, you'll hear us use a term Article 2. Oh, well, was this in Article 2 or not in Article 2? What the heck does that mean if you're not in this process? Article 2 simply means the section of the budget. There's 10 articles that show every spending thing, and some years they add an Article 11, which is lovingly called the wish list, which means you didn't actually get in the budget. It's kind of like, if revenue becomes available, do this with it. Forget Article 11, it doesn't mean anything. Article 2 is Health and Human Services. All your Medicaid dollars, all your CHIP dollars, all your special project dollars, your mental health funding, all of your programs that relate to Health and Human Services, Child Protective Services, all those services, foster care, things that go with those organizations are in Article 2. That's really, really key for people who care about health policy. Pay attention to Article 2. Now, if you're interested in graduate medical education or the training, that's actually Article 3 in the education department, but don't worry too much about that because the state hardly does anything anymore in graduate medical education, although we're fighting hard to get that money restored a little bit. But Freddie's going to talk about a little bit about that. So there's a couple of people that I can throw out that are, and it's kind of one of these Animal Farm references, like all pigs are created equal, but some pigs are more equal than others. So all legislators are created equal, but there's a few legislators that are more important than others. And when it comes to the budget, there's two people that are really critical. Dr. John Zerwas is anticipated, maybe tomorrow, to be named the chair of the Appropriations Committee. He becomes critically important. In essence, it becomes his budget that he writes on the House side. In the Senate side, Jane Nelson from Flower Mound is the Senate Finance Committee. She is tremendously influential and has been in that seat for 5 sessions now, 4 or 5? This is 5. This is her 5th session. She has long experience. She's been in the Senate since the early 90s, well-informed, knows every page of that. And then the third person isn't even an elected official. Her name is Dr. Courtney Phillips. Why is she important? She was recently named the Commissioner of Health and Human Services. For those of you that haven't had a chance to meet or read her bio or anything, she's only been in the state for about 3 or 4 months, comes highly recommended. She's from Louisiana originally, was in Nebraska as the head of their Health and Human Services Commission. How can an agency person have so much influence? It's pretty simple. Most legislators don't understand the nuances of Medicaid and CHIP. As a matter of fact, I can count on one hand, I don't know if you remember, but Annalee mentioned 181 members, 150 House members, 31 senators. I can count on one hand the number of House and Senate members that really understand health care and Health and Human Services out of 181. Most of them, when you try to go in and talk specifically, they go, oh, why don't you bring in my legislative staff person who really understands this, and you end up talking to them. It's not a bad thing. It just happens to be that healthcare is not their expertise, right? There's very few. So they rely on the head of the agency to tell them what happens if we say we're going to cut this program or we're going to add that program. And behind the scenes, every day, the commissioner is working with the staff, is working with those committee chairmen, and if that commissioner is advocating for your program, there's a good chance it's going to survive. If that commissioner doesn't know anything about your program or care anything about your program will probably disappear. Unfortunately, it's pretty much that simple. So those three people in the legislative process are super, super important. Can we influence them? Absolutely. There's a whole committee that they respond to. So there's plenty of people that we can talk to during these 20 weeks that can try to get something into the budget. One last thing I want to talk about as it relates to the budget is there's some little quirks and tricks that you can do as it relates to health policy, where you can give directives that don't quite have the power of law, but they can influence how money is spent. And these things are called riders, budget riders. And they're little directives in the very end of and a lot of people are like, oh, those are just end notes. No, those aren't end notes. Those actually have almost the power of law to direct agencies to do something or not do something. If you want to talk to Planned Parenthood, they kind of got beat up because they participated in a program that a lot of legislators didn't like. There was some language put in that, in essence, removed their ability to participate. They sued the states, going back and forth. There's a big legal battle. But these things happen in the back of that budget. So as you work with your members of the legislature and you get to understand this process, those little riders sometimes can catch you by surprise. A couple years ago, we left the legislature and we told the group of people that I was working with, we held off all of the cuts. In the budget, there's this number, everything looks really good. And then there was this little rider in the back that was called a cost containment rider. Sounds innocuous enough, right? Oh, it's just cost containment. No, it was about a $330 million cut to Medicaid. Oops. That one hurt a little bit. Now, were they able to squeeze out certain things from certain programs and move some things around? Yes. But a cut is a cut. And if all of a sudden $330 million is not flowing into a healthcare system, particularly one like Texas, people do feel it. The safety net systems feel it. The people who are most exposed to these programs feel it, and it was very real. So I've only described 40 weeks out of a 104-week session, or a 104-week cycle, right? So what do you think happens in the other 64? Regular operations. For the most part, that's when the legislature leaves in June, the budget is passed, the governor generally signs it. He's got this little line item veto. And by the way, almost everything we talk about, there's always little exceptions and little quirks and things that we could get into. Don't worry about them, they're just there. And in Texas, the governor has line item veto, which means he can go in, and if he doesn't like something the legislature do, he can literally take a red line, mark through it, and say, nope, we're not going to spend money on that. And then he signs the budget, and away you go. He can't add anything, but he can subtract things from it. Okay? But during those 64 weeks after the budget is passed, it gets implemented. The programs are running. Things happen. Nobody talks about the budget a whole lot. The LBB, which is a legislative budget board, kind of monitors how they're doing. They get variance reports every month, like, are we ahead of budget or are we behind budget? How are we doing? Are we spending more than we thought? And that's usually a little bit of a barometer that can tell you how we're doing. But I'm in all the years that I've been involved, hardly anybody pays attention to those reports. The comptroller gets involved a little bit, but it's just not there. So back to how important is the budget, right? Okay, go ahead. You want to stop? Budget process. So before we jump into how important is the budget, do you have any questions on the budget cycle?
Yes, that's what I want to do. I have a couple of questions on the budget, and I would like to start off.
Sure.
So, Annalee, you said you have a bill. A school mental health bill. Have you got a fiscal note on it yet? How much it's going to cost?
There is not a fiscal note that's been determined at
haven't.
this point.
Okay, but there will be some money involved.
Yeah.
There will be some expense. Okay, so I wanted you to reconcile, the budget bill is moving through with this big general revenue estimate for the next 2 years, big ticket items in there, higher education, Medicaid, jails and prisons, roads, public education. What happens if your bill gets passed? And I'm sure it will. How does your money get put into this budget process for your particular bill, and how does that get reconciled Can you,
Do you want to take it or do you want me to take
Sure.
it?
It's so in Texas, every bill is required to have a fiscal note on it, and the fiscal note it measures for the next 5 years. Is this going to cost the state money? Is this going to create revenue for the state or savings from the state, or does this have zero impact? And for the last several sessions, if the bill had a positive, if it was going to be a cost to the state, that was one of the ways you could kill it. Annalee mentioned ways to kill the bill. If it had any cost at all, the chairman were instructed, do not pass those bills out of committee.
okay,
We're in a session where there's a bit of a surplus. So now the question becomes, Annalee has a double fight on her hand. Let's just mythically say it's got a $1 million fiscal note. Now she has to get the bill passed, and then she has to go and actually fight for one of those little riders in there that I was talking about that says, if House Bill, what's your bill number?
906.
If House Bill 906 passes, in Article 2, line blah, 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 is directed to fund $1 million to the Health and Human Services Commission to execute the directives of that bill. And so now she has to actually go to a second committee and get that rider put on.
okay, thank you.
Sure.
Questions? Anyone on the budget?
John?
For a capital project that's in there, do they get to amortize that cost over the life of that project, or is it like a cash budget where the Ike Dike, if it costs $4 billion, you have to have it expensed at $4 billion?
So it's a great question because there's been all sorts of issues about this in the last really 10 years. For years, the tradition in Texas was we live on a cash budget, no debt is incurred. About 10 years ago, they started saying, you know what, that's crazy. We're creating capital projects. We're building buildings. If we do something that's going to last 30 years, we should be able to take out state bonds and do that. So the bonding authority to build capital projects. Now, the other thing that's really weird is, are you talking about, for example, a state-owned institution or a partnered institution or a project? There's all sorts of different things that they can do. But to answer your question in kind of summary, you don't have to come up with all the cash in 1 year's budget now. You can do a bonded project, which means you commit the state to paying for something over the course, the time period of those. What are they, usually 10-year bonds? Right. Usually 10-year bonds, yeah.
Any more? One more time for one more question on this?
So the commissioner of HHS was the one you said who was not elected? I'm
Correct.
assuming she was appointed by the governor?
Correct.
And she had rotated through a couple of states already?
Yes.
Did we land a successful one, a highly regarded one?
Absolutely.
Why was she brought in? What is sort of the expectations on her plate?
That's a great question. So, and we could have really an interesting long conversation about the reorganization of the Texas agencies that have happened over the last 20 years. But most importantly, the job of Health and Human Services Commissioner is a monster job. It is. That's Texas HHS, not even the HHS up there. And part of the reason it's a monster job is we consolidated a whole lot of agencies into one big commission. So finding somebody, A, that's willing to come to Texas and take on this job, B, has the expertise and the history to do that, and C, is willing to do it for much less than you would get paid in the private sector, which is kind of important because state employees don't get paid a whole lot. So she is making probably, I would say, a fifth of what she could make in the private sector if she was out in a competitive environment. But she's willing to do all those things. She believes in the cause. She's phenomenally talented, articulate, and she is, oh my gosh, probably one of the most high energy people I've been in around in a long time, and willing to really learn everything about the state of Texas. She's phenomenal. And again, comes very highly recommended. One of the questions that a lot of people asked was, well, why didn't you pick somebody from Texas? Why, was there really nobody in Texas? And I think the governor kind of looked around and interviewed a whole lot of people, and the few people that were willing to do it didn't have the expertise to do it. And the ones that did have the expertise to do it, I think laughed in his face and said, no way, I'm not doing that. And so that's kind of how the process has worked. Anybody want to put any color to that?
Let's stop there because,
Okay.
Thank you very much. Tim, now what I'd like to do is I'd like to hear Freddie. You've been quiet way too long, I know. We're going in order. Before we get into Medicaid, I hope we get into this, some of the, we're talking about the process of policymaking. I hope we get into what the state policies are in mental health, at least overview, and Medicaid CHIP. But before we do, Freddie, could you give us a little bit on, at the local level, we have things called county commissioners' courts and city councils, and they also make health policy. Can you say something about how the local health policy process works?
So I think set the stage here. I think that is important for the folks who are embarking upon a journey to learn more about health policy to understand that this is probably, as a subject matter, I would argue that this is the most complex subject matter that is considered at any jurisdiction of government. And if you think about the complexity and then you look at the things that are subject to federal jurisdiction, the things that are subject to state jurisdiction, the things that are subject to local jurisdictions, and they're all interconnected. And you've got an advocacy task that is basically, you always have to think about, which of these jurisdictions am I focused upon? What are the relative interconnectedness between each of them? So closing out, we really haven't touched much on the federal. We're focused upon the state. The local is also very complex. And if you think about this and you think about, we're going to focus on, just for purposes of the conversation, on Harris County and on Houston. But if you think about the conversation and you broaden it and you look more regionally and you think about the impacts of local jurisdictions on health policy, you've got counties and then you've got all the cities and the city's council within each of those counties that are going to be touching upon Health and Human Services policy and certainly Health and Human Services budgets. But let's start here in Harris County and let's think about the hospital district, Harris Health, formerly the Harris County Hospital District, jurisdictionally basically rolls up underneath the commissioner's court, so the judge and the 4 county commissioners. The judge and the commissioners actually appoint the governance, the leadership of the hospital district, the members of the board of managers. And at the end of the day, and Peg, if I misspeak, just throw something at me. I think the reality is they allow the leadership, the members of the hospital district's board to actually involve themselves in the day-to-day management and operations of the hospital district, and then periodically require them to come in and report on what's going on relative to the hospital district. But you definitely have governance that rolls up, the hospital district governance that rolls up, appointed members that roll up under the commissioner's court, obviously elected people. And within the hospital district alone, it's an expansive entity. You've got multiple health centers, you've got primary care clinics, you've got school-based health clinics, you've got a couple of hospitals that are they're household names in this community, Ben Taub, LBJ. And you've also got the interconnectedness between the hospitals and the medical schools, as those hospitals are the teaching institutions. They are the hospitals, the health systems, the teaching institutions for Baylor College of Medicine and for the medical school at UT. It's important also to think about, I think everything that we've talked about this evening has some type of a fiscal impact. And I've been at this for almost 35 years, the last 10 years in Health and Human Services. Nothing has changed. Basically, most of your advocacy is going to be focused upon fiscal matters. If there's no money, you can forget about whatever great policy aspirations might be out there. But think about the fact that if you own a piece of property in Harris County, for every $100 of valuation, basically 17.1 cents of every $100 of valuation goes to fund much of the operations of the hospital district. So if you're looking at your, when you get your annual statements from the appraisal district and you take a look at the value and you go down and you look at how much money has been peeled off for schools, how much money has been peeled off for the various things that are funded at the county level, you can look at Harris Health and you can see that 17.1 cents per $100 of valuation goes to fund the operations of the hospital district. Now, to be fair about that, is that enough for everything that a hospital district needs? If you think about the folks who are served by the hospital district, 60% of those who are served by the hospital district are entirely uninsured. I mean, I think from the outset, one of the speakers made the comment, you're sitting in the state with the highest percentage of uninsured, you're sitting in the major metropolitan area with the highest percentage of uninsured in the entire country, and more or less round numbers 1 in 5 of the folks who you interact with are going to be uninsured. But 60% of the folks the hospital district in its expanse serves are uninsured. About 20% are going to be Medicaid and Children's Health Insurance Program or CHIP eligible. And then another 20%, basically the remaining 20% is split in half between about 10% of the folks that the hospital district serves who are Medicare eligible patients, and then the final 10% is those who have commercial insurance. But it's basically, I try to explain kind of the structure, but also the way in which county health system for our county is funded, and then touch upon the fact that separate from the county, we also have the city of Houston's got jurisdiction over protecting and promoting the health and well-being of the community as well from the local jurisdiction's perspective. There are children and family programs that are operated through the city of Houston through the health department. You may hear the names Dr. Stephen Williams, Dr. David Purse. If you think about the things that impact the way in which EMS and the trauma system is supported throughout the region, you won't see a conversation that discusses trauma in our region without Dr. Purse being part of that conversation. But you've got such an expanse, and any of these things I would recommend that you go and explore on your own. But basically, everything from children's issues specifically to dental care, dental health, the clinical programs that exist in the city that are under the jurisdiction of the city that range from immunizations to men's health and to women's health. It's all over the board. And then as well within the city jurisdiction, just maintenance of things like health data for our city. We are increasingly, as we ought to be in health, we are increasingly data-driven, and a lot of the repository for a lot of the information that impacts the health and well-being or monitoring of the health and well-being of the city is managed by the city. Environmental health, emergency services, super diffuse functions within city and also county government to address the health and human services needs of our region. So with that, I'm going to close on the local jurisdictions, and then I guess we're going to come back up to talk about.
Yeah, maybe see if there's any questions first.
Any questions on local jurisdictions?
Local jurisdiction. And I really appreciate you sort of combine the process and the institutions with their responsibilities and roles, which I didn't allow Annalee to get into in mental health or Tim to get into with Medicaid yet, so we will. But are there any questions about the hospital district or anything local policy oriented?
I was going to ask about Medicaid expansion, any possibilities, why or why not?
Medicaid expansion, that's more or less a state, federal.
Can I answer the question?
Sure, let's go.
Not going to happen.
Okay. Oh, okay.
We're going to have an opportunity to talk about as we
Let's
get into policy stuff.
maybe. Do you mind if we get a little overview of Medicaid CHIP from Tim, and then we will address the Medicaid expansion?
I'm sorry. Did I?
No.
Tim, let's get a little bit of Medicaid expansion quickly in about a 5 to 5 minute overview, and then a 5-minute overview of mental health, and then we'll open it up.
So, am I on here?
No.
I'm on. My thing is on. There we go. Is that better? Okay. So Medicaid, and there's been a lot of conversation. Thank you for bringing up the Medicaid expansion issue. How big is Medicaid, and why is it that Texas has chosen not to do it? Now, I could be snarky and say it was just flat out politics that they wouldn't do it because of the person that passed the bill, and this was very anti-Obama, anti-presidential, and I think I would probably be mostly right. I could also make an argument that the way the folks in Austin have said is we don't want to commit to something that really doesn't have long-term sustainability, okay? And that's kind of a weak argument because the funding match is such a positive match rate that it's hard to rationalize why they wouldn't. But let me just back up for a minute. Medicaid is almost a $40 billion program annually in the state of Texas already, okay? And that includes supplemental funds for the safety net healthcare systems through what's called the disproportionate share program, which a lot of the local hospitals here in the TMC get very large chunks of money to offset their losses. The 1115 waiver, which we can talk a little bit about, I would actually argue that the 1115 waiver is the real reason why we didn't do Medicaid expansion. It's because we negotiated a waiver anticipating the expansion would be mandatory and we wouldn't need it. And then once we negotiated the waiver, we got all the money we would have gotten in expansion anyways. And so nobody really wanted to fight too hard for Medicaid expansion because we were already getting the money without any of the strings attached on Medicaid. So I can talk a little bit about that. But not only is it a big dollar program and that the providers rely tremendously on Medicaid, but almost 5 million individual lives at some point in every year right now in the state of Texas are either on Medicaid or have their services paid for by a Medicaid program. I mean, that's a big, big, big number, right? And so when you talk to legislators who, and Texas has a long history. By the way, this is not a partisan statement. If you go back when the Democrats were in charge, they weren't really big fans of big government programs either. Texas has never willingly jumped into big government programs. As a matter of fact, Texas was one of the last states to start Medicaid. I believe it was in 1971, and most states had started it in like 66 and 67. So Texas has always been a little late. We were the last state to start a CHIP program. Of course, within 6 months, we'd ramped it up and we had one of the best CHIP programs in the country and had more lives covered. But we were very slow to get involved. That's somewhat by our nature, by Texas's nature. By the way, I'm from Colorado. I'm not originally from Texas, so I've lived here for almost 30 years, and so I almost feel like a Texan, but it's kind of fun because being not from here, I can look at some of the things and go, wow, why do you do that? What's going on here? And there's various history and there's reasons of what's going on. But the biggest thing that people need to remember is that all those property taxes that Freddy just mentioned, and all that demand for services, whether it be mental health services or trauma services or primary care, all those other things, depending on which kind of service delivery system you're involved with, they cost money, right? And how do you pay for these things? So let me back up just real quick. For those of you that don't understand that kind of Medicaid expansion population, it's pretty easy to describe. If you think about age, the age on kind of an x-axis of a graph from 0, or I could actually argue -9 months, because a mom actually isn't covered because she's a mom. She's covered because she's carrying a baby. So life actually, according to Medicaid, is the -9 months. And then all the way up through 65, if you put that on the x-axis, and then if you put income on the y-axis mentally, and you put the 100% of the federal poverty level and the 200% all the way up to 400%, 0 to 18 in Texas is covered all the way up to 200% of the federal poverty level in Medicaid, right? There's a lot of kids covered in that program. The Affordable Care Act expansion of coverage subsidizes families with children that are between 200 and 400% pretty heavily, so you got a lot of coverage there. So children are pretty well covered. If you go to 65 plus, everybody's in Medicare, although if you need long-term care services, you get covered by Medicaid mandatorily. They're in that program, right? But if you look at the ages between 18 and 65, and you look at the way the Affordable Care Act worked, they've got these great subsidies starting at 400% of the federal poverty level all the way down to, and I'm going to get technical here, it's 133, depending on which program you're looking at, it might be 100, but just for argument's sake, just pick 100. It's an easy line to draw. 100% of the federal poverty level, or the poverty level, 1x, that's it, 1 times the poverty level. And then you say, okay, you've got all these subsidies that people can choose in the Affordable Care Act, but the people below 100% of the federal poverty level between 18 and 65, what do they get? They're actually not making enough to opt into the Affordable Care Act subsidized care, but they're in this big gap. Turns out that if they have a disabling condition or they are a caregiver of a child and they're below that level, there's all sorts of kind of little special programs that are along the way, but that population is uninsured right now. And they've always been uninsured. And we had the opportunity before the Supreme Court ruled it as an option to cover them in Medicaid. And that is the gap. And when people say the Medicaid expansion, we didn't cover the Medicaid expansion, it is specific to 18 to 65-year-olds, healthy adults, below 100% of the federal poverty level. We can do that. It's available right now. If they show up at Memorial Hermann or at Harris Health or any of the services, they end up on the uncompensated care roll. And because of our wonderful waiver that we got, those hospitals will generally get paid a little bit for that. They definitely won't get paid Medicaid rates or anything else, but they will get some amount of money to offset that. So that's part of the pressure that was lifted from forcing us to take Medicaid expansion. That's a really long answer, but that is kind of what I've watched. And I can tell you, I've been in the legislature every year for the last 3 sessions fighting for Medicaid expansion, fighting for an alternative to Medicaid expansion, fighting for different ways of doing a Medicaid expansion. And if you say Medicaid expansion, about all of the Republicans, with the exception of a few, just say, oh, stop talking, I don't want to hear about it. And most of the Democrats go, that's a great idea, let's do it, but we don't have enough votes, so thanks for coming, but we won't do it because we don't have enough votes. So that's kind of the reality.
Could I just add? You go ahead, Annalee.
Well, what I wanted to say, I absolutely agree with Tim, but I think the one caveat could be maternal mental health. This is, obviously Texas has had some of the worst numbers in the country regarding mothers who are severely impacted by their birth or unfortunately died during or right after birth. And there is finally a conversation about extending the benefits from the 60 days that the mother is usually covered, extending that perinatal CHIP benefit to the full 12 months in which postpartum depression can be diagnosed. But I've heard Republicans talk about it. I've heard Democrats talk about it. We've heard Democrats talk about it for multiple sessions, but it's really possible that it gets through this time, but I have been told it won't get through if we call it Medicaid expansion. It will get through if we call it Medicaid extension.
Medicaid extension? What? Medicaid extension?
Extension, because you are extending, well, you are giving her more benefits and thus expanding Medicaid. You are really just extending the amount of coverage time that you're giving the woman. So,
and I love looking out, and I see so many crinkled foreheads and kind of tilted heads like, you've got to be kidding me, right? And Annalee is not kidding you. Words have power, and how words are out in the Twitter sphere, and how things get represented in the media, and all these things. I wish we could take away some of these ugly, powerful words and talk about coverage. Does it make sense to cover people? Of course it does. Everybody that's ever studied health policy says if you have a divided population where a whole lot of people have no coverage and you have people with coverage, the entire market has to do all sorts of contortions to try to provide services to people who don't have coverage. The number one way to start good health reform, it's not the end, but it's a good start, is by getting everyone covered. Then you can actually start improving some of those economic principles.
A couple of macro comments on that kind of at the philosophical level. If you are a person who does not buy into the philosophical belief that it's the responsibility that the government of the United States and the state has a responsibility to move towards universal coverage of its population, of its citizens. If you don't believe that premise, okay, then what makes Medicaid expansion hard to convince people who don't believe that as the premise, their premise is, as Tim was saying, it's already costing $40 billion out of $110 billion.
No. That's an all funds thing. Don't try to compare.
$40 billion.
It's $40 billion annually.
All funds.
All funds.
Annual. And the state budget, all funds, is around 115, 120 billion. So it's about 30% of the budget already.
Yeah.
Okay.
All funds.
And it only provides services to about 4.5 million of our population, and we have what, 27, 28 million people in Texas, okay, who benefit zero from this, right? So it's a significant fiscal issue, unless you believe it's a moral issue. So that's kind of the friction that we have, and that Tim has been up against over the years and fought strongly against.
Valiantly, I might add.
Valiantly, and actually there does seem to be a little crack in the door opening this session. We'll see. Freddie, you have anything else to add
Well,
on this issue?
on this issue. So I also argue that, I argue with Republican lawmakers that if you really want to consider conservative principles, just as you would not let your roads go to hell and you wouldn't let your water resources and your air quality go to hell, you ought not let your Health and Human Services safety net go to hell. And if you really take a look at the states that chose to expand their Medicaid programs, every single one of their uninsured rates went down. And I like to debate and argue this subject. And I also like to analogize to try to make people, give them something that's a little bit easier to think about and think, okay, everybody fills up their car with gas once a week, thereabouts. You think about how much you're paying in gasoline taxes, and you think about how much you're paying in federal gasoline taxes. So for every $1 federal gasoline tax that we send to DC, we're getting 91 cents back as a state. And for many, many years, we were getting less than 80. We were getting about 77 cents until not 20 years ago. So you think about that, it ought to really tick you off to know that in Pennsylvania, for every buck, they're getting $1.28 back. Well, think about it in the context of how we invest in a growing population, a population that has a lot of uninsured people, highest percentages we've talked about, a growing population of Medicaid and Medicaid eligible folks, and they're going to get sick and they're going to show up and they're going to expect that we're going to be able to care for them, and we are choosing as a state to forgo some dollars that would pay for or underpin some part of their care. And by forgoing that, then we have to come up with a convoluted, to Tim's earlier comment, we rely upon a bunch of buckets of supplemental payments coming from those jurisdictions we talked about earlier, federal, state, and local, any of which is in jeopardy at any given time. Any one of those is problematic for our system. We're the largest provider of care to the uninsured Medicaid population in the region. All of the private systems and the public systems, if you take any one of those unfortunate several buckets of money off the table, that's the difference between one of us keeping a hospital open or not. You take any two of them down, you really have a problem. So I've made the argument historically that a conservative principle, if you're a real conservative lawmaker, forget if you ran as a Republican or Democrat, you ought to care enough about the infrastructure, which includes, and one of our messages that we've tried to deliver, not just as our system, but trying to encourage the healthcare sector to deliver, is that we ought to be considered infrastructure. We ought to argue as we are representing infrastructure, just like the highway folks do, just like the refining folks do, just like the waterways folks do. So this is a philosophical thing.
Right.
Chuck, I
Right.
love you.
Infrastructure, I like that word.
But I also, I share the moral argument, but
Yeah.
I also look
Yeah.
at it from a perspective of what is a real conservative principle. And if you espouse real conservative principles, would you let your infrastructure, including your Health and Human Services infrastructure, suffer?
Okay. We have a brand new plan for a major psychiatric inpatient facility right across the street. Could you end a little bit on a more positive note about mental health policy that has been quite significant in the last legislative session, and it sounds like there's also going to be quite a big mental health agenda come out of this session. Can you summarize a little bit what the state is doing
Sure.
in mental health policy these days?
I can't. I got an email today about the new policy, new facility opening, and I did not get a chance to fully read it. But what I will say is probably since 2011, so is that the 82nd legislative session, we did start to see an increase in funding for behavioral health care. For those of you who don't know, mental health care has now been, we're trying to rebrand it to behavioral health because behavioral health is a more comprehensive term that actually includes substance use. And we think it's a more appropriate it's the more appropriate nomenclature because it addresses those who usually have mental health and substance issues as they're so often comorbid. So we saw the funding increase. We saw in the in between the 84th and the 85th, For Price convened the Select Committee on Mental Health. This was a committee that met during the interim. They had 8 hearings specifically related to mental health supports across the state. They wanted to know who was accessing services, how they were accessing them, if they were accessing them successfully, what were good programs, and where do we need help. So at the end of that, one of the things that I was so impressed by was you really got these 9 members of a committee who came out educated on mental and behavioral health issues, engaged, because it's so hard to sit in one of those hearing rooms and not be impacted by all of the stories that you're hearing. And every single one of those legislators ended up filing at least one bill that covered mental health, some of them more than one. And then again, after this legislative session, Chairman Price formed the Committee on Opioid and Substance Use. And so they're specifically studying opioids and other substance use and their effect on our communities. Just another thing, so in general, we're seeing a greater understanding of mental health and behavioral health in the House and Senate. We're seeing a reduction in stigma. We're more willing to talk and have these conversations. And then you're seeing also kind of a growing cohort of advocates who want to make sure that we are actively pursuing policy that will look at prevention, because we understand that if we don't prevent or work to prevent mental health illnesses as soon as we can, that will just bleed over into all of our social facilities. And so that's when you see kids ending up in the juvenile justice system, where you see super utilizers rotating in and out of emergency rooms, and again to finally state prisons and jails. This session is going to be very interesting. You always sort of plan for the legislative session with all of these great ideas that you want to pursue in that session. And then whatever happens in the interim totally blows that out of the water, and you just have to deal with whatever happened. In Houston specifically, we had 2 incredibly significant events that have shaped the narrative of this upcoming legislative session. So Hurricane Harvey in September of 2017 and the Santa Fe High School shooting in May of 2018. We already, after Harvey, knew that there was going to have to be a conversation regarding infrastructure and rebuilding, but I think for the first time we were starting to realize that we needed to have a conversation about mental health and trauma, because you had an entire community who was impacted for days and days and days, just inundated, not only those who lost their homes or had to go to shelters, but kids watching their neighbors be flooded out. You know, they were impacted by the trauma as well. Once you had Santa Fe, though, that really opened the conversation up. I think I always joke that the legislature is so afraid of talking about guns that they were finally ready to talk about mental health. So after the shooting, the governor went into action. He held a series of 3 roundtables. The lieutenant governor convened a select committee specifically tasked with studying school violence. Then Speaker Strauss put new interim charges on existing committees, and the TEA for the first time requested a special legislative appropriation request specifically dedicated to school safety. The big 4 issues that came out of that, kind of a twofold school hardening approach, and so that's where you're going to get the metal detectors and additional school resource officers, but the kind of final piece to it really does have more to do with prevention and mental health supports. So much of our legislative agenda is going to be focused on school-based mental health supports, with the idea that if you can bring prevention into the classroom, if you can come up with a school-based comprehensive system of care, you can not necessarily prevent these events from happening, but you can create a safe, supportive school environment where kids feel supported and are better able to cope when we do have unfortunate events occur in our community.
We have limited resources in schools now dealing with mental health counseling available to children, very limited, and
So this always blows my mind, but I guess we have school counselors who I think traditionally when our parents were growing up dealt with behavioral health issues and academic issues and kind of everything in between. Now they're so overburdened with ensuring that tests are taken, test scores are high, these kids are getting into college, they're dealing with disciplinary issues, that you've really lost that behavioral health piece. And so not only, do we have behavioral health counselors in our schools overwhelmed with their duties and responsibilities, but the sheer number of kids to counselors is just overwhelming. The recommended ratio is 1 counselor per 250 students. Commonly, we are seeing 1 counselor to 540 students, to 750 students in HISD, 1 counselor to 1,604 students. So even if we had them doing purely behavioral health interventions and supports, they are too overwhelmed to even address the need in a tiny way. So we need to not only get resources into the school financially, but we need to think about alternative ways of getting professionals into the school. So Legacy has a really wonderful proposal about school-based clinics, which offer primary care and behavioral health care on site in the schools. Beyond that, we want to make sure that teachers understand how to recognize signs and symptoms of mental illness. If they spot someone, they want to be able to refer them to a behavioral health professional. We also want to make sure that as kids are being identified as potentially needing supports or potentially needing off-campus placements, that we do that with the intention of getting them back to school. And so this is not, we're going to get this bad kid out of here, and so we're all better off. We're thinking about the kid himself, and that kid needs to be rehabilitated and successfully re-enter the classroom.
Thank you very much for that. Freddy, we've run out of time. In 15 seconds or less, can you summarize healthcare workforce and long-term care? I'm only kidding. I want to apologize, Freddy, for. Can you give us
So how about a couple of data points?
a couple of data points?
All
Okay,
right.
we've got to get out of here in 1 minute.
Would you all be surprised that the health sector is now the largest U.S. employer among all sectors of the United States economy? All right, as of 2018, that is the case. So we've got about 160 million people working in the healthcare workforce and a growing number. In the aging population, and if you are talking to folks who can't figure out what to do when they grow up, there's nothing but good careers and opportunities. And even if you look at a medical center where we've had some institutions that have laid off significant numbers of people, every single one of us has got opportunities for those who are physicians, nurses, clinicians, those who want to actually be involved in direct patient care.
Great. Even more employees in HEB?
Yeah. Yes, sir.
160 million?
I'm sorry.
310 million Americans?
Okay. I'm old and curmudgeonly, and I need to take a look at my numbers and think better. 160 million is the current U.S. workforce, but we're 13% of that and growing. Thank you.
Yes.
You guys would have walked out of here with a really bad data point.
Thank you so much, panelists. Thank you all for coming.